So hello, my name's Emma Wood. I work in the support team at the Brain Tumour Charity, and I'm here today with Dr Anthony Byrne, who is a palliative care consultant and the clinical director of Marie Curie Palliative Care Research Centre in Cardiff. So thank you so much for being with us today, Anthony.
You're very welcome.
Thank you. So we've got some questions coming out from our community that we wanted to share with you today. So thank you for taking the time to respond and to help us answer these. So the first thing that I wanted to ask you was around the issue around DNRs. So we know that it's been in the news recently, and we've had lots of people in the community get in touch to say that, you know, is that going to be put in place for them? Why are they being contacted? So could you just help provide some information around that for us?
Absolutely, and I think there are two main issues really to think about when we talk about DNR. One is our understanding as a patient and public what DNR means and stands for, and also the why now. Why am I being approached about it now in the current context of coronavirus? And in a sense, the DNAR description is a bit of a misnomer really, because it suggests about do not attempt resuscitation. But in actual fact, as healthcare professionals, we think of a whole range of interventions that are a level of resuscitation. And the resuscitation at the most extreme end of that spectrum is cardiopulmonary resuscitation. But if you think about it, IV fluids are a type of resuscitation, antibiotics are a type of resuscitation. So we will speak to patients and families about various levels of resuscitation, with the most extreme end being cardiopulmonary resuscitation, where that implies if one's heart stopped, that there would be compressions of the chest and an attempt to restart the heart, or a tube put down into the lungs and a ventilator used to support ventilation. And that is at the most extreme end of the spectrum, but that is the level of resuscitation that most doctors are referring to when they talk about DNAR. So I think it's really important for patients and families to understand that we are very anxious and keen to talk about a degree of resuscitation that's appropriate for them, and that the most extreme end of that spectrum, if we are less well, and particularly if we have an advanced cancer, an advanced or a high-grade brain tumor, that level of resuscitation, that we have very good evidence that it is unsuccessful, and it is a traumatic undertaking and can be very undignified for the individual. And it is therefore an intervention that, if it's futile, we of course would not wish to undertake. But all other levels of resuscitation that would help and support a person to stay alive or be more comfortable would all be levels of resuscitation we would want to discuss. And there is a perception, I think, out there, particularly at this time, that some of those decisions are being made at a population level or at a blanket level, that if you're of a certain age or if you've got a certain condition, that you definitely wouldn't be offered that high level or extreme level of resuscitation. And I think it's really important to get the point across that at the time of coronavirus, but most importantly, outside of the time of coronavirus, those decisions are made on a very individualized basis. And what we do is we use the evidence base that's very clear and very evident about the types of condition that would mean cardiopulmonary resuscitation would be unsuccessful. And we apply those to the individual so that we can make a decision that's right for you, and explained in a way that helps you understand the reasoning behind the decision, rather than trying to seek an opinion on whether it's the right or wrong thing to do. And sometimes families get very distressed that they're being asked an opinion on whether somebody should be resuscitated or not. And that's the fault of the way the conversation has gone, because in reality, what we should and must be doing is bringing a patient and family along in the discussion to an understanding of why that level of resuscitation would be inappropriate. And I hope that makes some sense.
Definitely, thank you. And I think just to have that clarified is really helpful. So with that in mind then, what sort of care, if somebody with a brain tumour was to become unwell with COVID-19, what sort of support and care is likely that they would receive in hospital?
So I think first and foremost, preparedness is the key. And if we are thinking that levels of intervention are going to be honed according to the individual patient and their background illness and how unwell they've been in recent months, that the more information and understanding one has of that person and that person's life and experience, the more accurate the decision making is going to be. And that's where the timing of this conversation now becomes really important, because actually, as a patient, the person I would want helping me through that discussion would be the person who knows me best as a healthcare professional and in whom I trust. And so the reason patients are being approached now in advance of any problems arising, particularly if you've got a high-grade brain tumor, for example, or more advanced brain tumor, the reason you're being approached now is that we want to have conversations with you because we know you well, and hopefully we've got rapport and trust with you, rather than leaving it to an emergency situation where you're being assessed by and having discussions with a healthcare team who will be excellent and professional, but who don't know you as well. So in these extraordinary times where things can change quite quickly, not only I think is it right and proper that you're being approached about these conversations now, but actually if you haven't been and you feel that you have a degree of vulnerability and perhaps that level of intervention would be unsuccessful for you, I would really encourage you as a patient and a family to be having those discussions ahead of time. And if you are admitted to hospital, then all of the other levels of resuscitation, even if a DNA CPR order was in place, would be discussed and available to you, and the level that the intervention takes would be the level that's right for you. And that would include IV fluids, IV antibiotics, oxygen, either by nasal cannulae or a mask, and sometimes via a pressurized mask. Would all of that level of intervention around antibiotics and oxygen be available, but of course all of the extra support from the medical and nursing team that is so important when somebody is ill. So it's very important that in making a decision about whether or not to come into hospital, that you understand that a DNA CPR decision, as appropriate as that might be, is not a decision not to engage in other levels of intervention that would help.
Thank you, that's really helpful. And I suppose that leads on to the next sort of question that we had. So how do families make the decisions around whether to come into hospital or whether to stay at home if they become unwell with COVID-19? How would you advise families in that situation?
And I guess the decision is going to be very individualized. I think that there will be, if one is becoming less well and has already been less able because of your background condition, and you've had a discussion with your oncologist or your neurosurgical team, or perhaps even your palliative care team, then the decision has to be around whether or not your absolute preference is to be at home as part of your future care planning, or whether you would prefer to be in a hospital setting for the types of intervention that I've just described. And thinking ahead about that is really important, because you are then best placed, if you know the types of intervention that would be available to you, to decide the extent to which that would improve your quality of life and your comfort, as opposed to, for example, being in a home setting. And the earlier you've thought that through and had conversations with your family, and really importantly with the healthcare professionals that you trust, then the easier it is going to be to make a decision at the time. And there'll be much less conflict in your mind and much less distress for your family if you've kind of made a large degree of that decision making ahead of time.
So if people make the decision to be at home, how can they access care, and what would that look like?
So if you made a decision that you wanted to stay at home and under no circumstances go into the hospital setting, even if you were to become less well, then the key thing again is about preparedness. And I mean not just preparedness for healthcare professionals, but preparedness for you as a family. So if you made a decision that you wish to be cared for at home, then every attempt will be made by the healthcare professionals around you to make that a reality. But it is really important, particularly at this time of very stretched resources, that discussion is had now rather than waiting for an event like being COVID positive to happen, so that with your district nurse and your GP and your palliative care team, that you can start planning as to what sort of care that you would need and what additional support your family would require, and really pragmatic and practical things around like having a hospital bed at home, having equipment that would otherwise support you at home, and indeed even having things like medication at home, that if you were unable to swallow, that we could have medication at home just in case that arose, so that we could give you medication by injection instead. And so under normal circumstances, in our non-coronavirus times, we would want you to be having those discussions as part of your advanced care planning and your future care planning about what you would want if you were becoming less well and perhaps coming towards the end of life. And we would put it in place a plan that would include additional support for your family. The reality, obviously, at this moment in time is that in each locality and where you live may be different to situations elsewhere. It's very unpredictable how stretched those resources are going to be. So the earlier you have a conversation with your oncology team or your GP, the earlier that you can access palliative care services and have an honest conversation with them about the types of availability from your district nurse and the palliative care services, so that families are prepared for the reality of what it would mean for caring for their loved one at home.
Thank you. And I suppose, just to sort of finish off, is there any other advice that you would offer to families? Anything else that you'd suggest at this time?
So, I mean, it's quite a bewildering time, isn't it? And we're overloaded and avalanched with information every time we turn on our TVs or put on our phones about coronavirus. And particularly distressing when we're otherwise unwell and can feel very isolated. So I think there are several things that are important to remember, and that is that for more people than not, having coronavirus means that we become unwell and have flu-like symptoms and have a fever and then get better, and we may feel fatigued afterwards, but we get better. And that, you know, the media approach is very much focusing on the extreme end of the spectrum. So I think it's really good for patients and families to give themselves some media-free time, and to be kind to themselves and each other in doing that, and particularly avoiding social media and sites that are not really trustworthy. And so really relying on information sites like the main news outlets and sites like the Brain Tumour Charity and government websites is so important, because there's a lot of misinformation out there. So be kind to each other as a family and avoid all of that misinformation, because it becomes extremely stressful. And in terms of that information, I think that it would be really helpful to not be waiting for healthcare professionals to contact you. Be proactive. Think through the things we talked about advanced care planning, and we will include a link on the website to the Brain Tumour Charity's pages on advanced care planning. And also in terms of informed decision making, making decisions that we feel are right for us, I'd like to guide people towards a website called Talk CPR Wales. And this is a website that was co-developed by patients to talk about the realities of what CPR is, and includes video clips of a patient talking about why they decided not to have CPR, and also healthcare professionals describing the reality of what CPR is and why in certain circumstances they would not wish for it. So I think it's a very powerful resource for patients and families to consider. And again, we'll have a link on the website to that, because the more informed we are, the better our decision making will be. And that final comment is, you know, preparedness is everything. And, you know, the hope is that nothing will happen, and that everybody will remain safe and well at home. But it's really reassuring and reduces our stress and conflict levels if we planned ahead.
Fantastic. Thank you so much. Some really useful advice there, and we really appreciate you taking the time to speak with us today. So thank you. Thanks ever so much.
You're very welcome.